Good morning, everyone, and welcome to Within Second Annual Within Summit. My name is Ashley Barkoviak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I would like to introduce you to Ronnie Lee. Ronnie Lee is a licensed psychologist in the state of Texas who recently completed his postdoctoral fellowship at Baylor College of Medicine and received a doctoral degree in clinical psychology. His prior clinical experiences have consisted of Jackson Memorial, University of Miami Hospital, Regional Memorial Neuroscience Institute, and Clementine, Miami. The majority of Ronnie's training has taken place with a medical or residential setting, with a particular emphasis on behavioral medicine, eating disorders, consultation liaison, special immunology, and psychological assessment. Currently, Ronnie is a primary therapist here at Within Health. We are so happy to have him here with us, and he focuses on the treatment of eating disorders here. Ronnie will be presenting on the topic of eating disorders and cognitive impairment, a brief review of consideration for telehealth testing. Before we do kick things off, I have some general information to go over in regards to the CEU credits. Evaluations will be sent to your email that you use for registration for the presentation. Once the evaluation is completed, you will receive a link to download your CE certificate. Please utilize your CEGO dashboard for all things CE related. The video of the presentation will also be available on your CEGO dashboard. However, you will not get credit for watching the video unless you attend it live. The credit will be given to those. And if, like I said, if you need to access anything, that'll be on your CEGO dashboard. If you have any technological issues and need to change devices during the presentation, you will receive credit for that. For any additional questions, concerns regarding obtaining CE credit, please feel free to email either myself or Jamie Singletary, which will be provided in the chat. I also will provide the CEGO resources as well for any support that happens within CEGO itself. Now I will pass things over to Ronnie. We are so excited to have you again.
Thank you so much, Ashley. I appreciate it. And just a quick thank you to Kate Scafati and Jamie as well for reaching out to me and asking me to be a part of the Within Health Summit. Funny enough, it was about a year ago I started here at Within, and one of the first things that I remember actually is watching the presentation and listening to the talks of the Within Health Summit last year, and I definitely wanted to be a part of it. So I'm excited to be here today, and hopefully we'll be a part of it in the future. As Ashley mentioned, I will be talking to you all about cognition and eating disorders, giving a brief review and considerations over telehealth testing, and what that will look like in a virtual setting. So my idea of today's talk is really to be as general as possible. I think that it'll be really helpful to maybe do a follow-up to this and be quite specific with specific batteries. But I just want to give a brief overview. I think that this is long overdue, and there's so much research that has been going on since really since 2 decades ago on virtual testing and the efficacy and the norming of it. And then there was kind of this general spike around 2019 when COVID hit us pretty hard, right? And I remember at that time I was at the Dallas VA, and we were really just trying to navigate what does cognitive testing look like in this realm, and who would need it and who would qualify and things like that. So I want to start off with just a quick quote, as I always do with my presentations. Our minds influence the key activity of the brain, which then influences everything: perception, cognition, thoughts, and feelings, personal relationships. They're all a projection of you. I thought that was beautiful. I was trying to come up with a really clever way to tie that in specifically to some of the things I was talking about, but I wasn't able to. But I do like that quote just in general. I just want to quickly also say that in no way am I an expert in this area. A lot of this is just from really just my own research and review. I do have past experience, as Ashley mentioned, at Jackson Memorial. I did quite a bit of cognitive testing there for a year. Also at the Neuroscience Institute with Dr. Bros and Regional Memorial in Hollywood, Florida. They do amazing work over there. I was a psychometrician as well for 2 years. So a lot of this also is just my experience with cognitive testing. All right, and I kind of already went over like what I want to do today, but just generally, I want to make sure that we have a working understanding of what cognition is. I feel like there's a lot of working parts to that. be able to identify, what the relationship is between cognition and eating disorders. I think the reflexive thought is that there is a significant relationship, and while there may be, I think it's a little bit more complicated than that. I have some literature that I'd like to review with you all that I think is pretty interesting and shows the need for awareness of cognitive functioning in this population. And then what are the neuropsychology aspects? Okay, I wanted to bring awareness to this, what the literature says, and just give some considerations for the future. So I got this definition from a book, Cognition and Intelligence, Identifying the Mechanisms of the Mind. I didn't read the whole thing, but the chapter on cognition, I thought that this was a really eloquent way to generalize cognition. So I'll read from the slide. Cognition refers to the range of mental processes relating to the acquisition, storage, manipulation, and retrieval of information. It underpins many daily activities in health and disease across the age span. Cognition can be separated into multiple distinct functions, depending on particular brain circuits and neuromodulators. So if you've worked with me with a client, or you've been a part of my team, you most likely have heard me talk about cognition in some way. And maybe it's part of my training or just kind of learning from supervisors in the past, but I feel like cognition is one of those things that can easily fly under the radar, right? You all are here now, and you're, actively paying attention to this talk. You're using, visual processing, auditory processing, what I'm saying, making sense of it. Some of you also may be engaging in multitasking as well. So like this task switching that you're doing, which is a big part of cognition. With aspects of working memory, right? Being able to intake information, manipulate it, or come up with our own thoughts, and then express it or think about it, right? Or even the idea of metacognition, which is even thinking about cognition. These are all things that happen so fast, and I think sometimes we take them for granted, right? And I think about this in the clinical sense, right? We are asking a lot out of our clients. Right, we're asking them to be a part of this program, which in many ways can be quite demanding for the better. Right, asking them to be an active participant in individual sessions. Right, so we take somebody in PHP, 3 sessions per week with their individual therapist. Sessions with their RT, with their RN, with the CP, with psychiatrists, right? So it takes a lot, right, of attention and awareness. And then obviously in the group settings, right? So we have many group therapies that are offered throughout in the supported meals, and taking a step back from it, right? If we kind of use this definition, we're really straining cognitive abilities, right? But that's why it's there, right? Our cognitive capacity is there to be strained. That's what we do as humans, right? That's what makes us unique in many rights. But I really want to focus kind of on what are the different parts of cognition that if interrupted, right, or if there is a identifiable deficit, what does that mean for kind of overall thinking and being able to engage at a high level? So there's this other or quick kind of more simplified definition of cognition that I also really like, right? It's the processes an organism uses to organize information. And I think, again, it kind of goes off what I was mentioning on the previous slide, right? Is that we're really asking a lot out of our clients in terms of taking in information after information after information. I mean, imagine going from one nutrition session, right, then to psychotherapy, right, and then we get psychoeducation from our nurses and so on and so forth, right? It's a lot of intake, and it can be really difficult to organize that information if we're not working at a high level cognitively. Again, right, we're working under the premise that the majority of individuals are, but what about the individuals that are not, right? Or what about the individuals that also have co-occurring diagnoses that are impacting? I think about our individuals with ADHD, right? If we know that there's an ADHD diagnosis as a clinical team, what are we doing to help assist with that, right? Do we know what type of ADHD it is? Is it a combined type? Is it inattentive? If it's inattentive, what are we, or how are we preparing our treatment plan, or excuse me, treatment map, right? To help assist in that. So again, I just want you to, think. I'm going to talk a lot about kind of cognition and assessment, and it may not seem directly related to the clinical side of things at times, but I want you to kind of be thinking about, okay, how does this relate to what we're asking of our clients clinically and what we are doing as a treatment team, as clinicians guiding this process. I will also add, I have here that, it's different than IQ, and that goes without saying, but I think sometimes it can be forgotten, right? So long ago, IQ is kind of, or just knowledge in general, is kind of separated into fluid versus crystallized. Crystallized being the knowledge and information that we're able to hold on to over time, and we really don't see a decline in that, right? As we age, as things occur, it's kind of famously like if you have loss of consciousness, or have a bad TBI, right? What should stay around is your crystallized knowledge, or your crystallized intelligence. The fluidity of that knowledge, right? I think that's more so kind of in line with cognition. I hope I'm explaining that right, or I'm explaining it to where you can understand. And I think it's important just to make that separation, right? Because we have extremely intelligent individuals across the board, and so many intelligent and magnificent clients, right? That we're not wanting to or need to test IQ at all, right? It's more so the cognitive day-to-day abilities that could drastically change, right? And we take a look at this graphic on the right. We have decision-making, attention, emotions, memory, control, thinking, sensing, and even under memory, right? We have working memory, we have episodic memory, declarative memory. What does the storage look like, and the manipulation of it, and then being able to express it, procedural memory, semantic memory, and so on and so forth. So again, it just reinforces the fact that yes, we are all actively taking part in this, and this is something that is occurring really in a split second. But what if those processes are or if there's barriers to those processes, right? So this is I use a big slide for one specific bullet, but I was going to take this out, but I was like, you know what, I'll just leave it. I'll ask you all, because I'm going to be talking a lot, and I think I can see your responses. I'm just curious for the participants here. If you don't mind popping in the chat, or if you don't want to pop in the chat, that's fine. Just thinking about what are the things that could impact cognition, right? If we think about our clients, if you're really, no matter the discipline that we're in, what are some things that we feel like can impact cognition? Yeah, most definitely. Shows us stress, 100%. And so I'll chime in as well with these. And if you think of more, please feel free to pop them in the chat. Sleep, right? Sleep is a huge one that can impact our cognition. And something that I'm really interested in, especially when I see clients, or it's been a while since I've seen a client, I always ask, how has sleep been over the past week? Yes, nutrition, of course. That's in many rights why we are here. Nutrition plays a big role in our cognition. Pain, most definitely. I did, or part of my practicum was at Jackson, and I was in, I forget the unit, but part of it was kind of this chronic pain unit, and also burn unit. And we did a ton of cognitive testing there, and it's really remarkable how much pain. So yeah, I appreciate that, Jill. Mood for sure, anxiety, depression, trauma, those all impact. I love that, Anna. Medication, side effects from medication, right? They can impact. But yeah, we could really list all, and that's why I didn't list. I'd rather you all do it, because I could just fill up all of these, the whole screen, right, with different bullet points of what impacts cognition. Virtually everything. But I think the key to take away, right, is the wording, impacts cognition, right? So many things impacts cognition, and our cognition is probably impacted now, in some respect, right? So if we think about, if we had a long night, if we didn't nourish ourselves properly, we didn't sleep well, whatever it may be, and we wake up the next morning and we're just not feeling the best, right? We're fatigued, and you're asking your partner or your family member, could you repeat what you said again? Like, I can't get it, right? Cognition is impacted, right? It's not long term. We'll probably quickly turn around after we get water, after we hydrate, and things like that. But what I want to focus on is kind of what happens when it's a little bit more long term. So this slide looks at cognitive impairment versus cognitive deficit. I really want to focus a lot of the attention and kind of just thinking about this presentation from the lens of cognitive deficit, right? So for cognitive impairment, I'll just start there very briefly. I'm really not in the business to diagnose that, especially not in a virtual setting. So with the MCI, it's kind of like this expected diagnosis that could be a precursor to mild to major neurocognitive disorder, right? Or neurocognitive disorders, which can be secondary to Alzheimer's, Huntington's disease, Parkinson's disease, and so on and so forth. So MCI, I don't take that diagnosis lightly, and while I can, as a psychologist, diagnose MCI, it would be really rare for me to do it. Like, you'd have to have, I think, a pretty good battery of tests to say, okay, this is why I believe there's a mild cognitive impairment. Now, if there's a neurologist or a physician, right, they can diagnose that without any testing data. But that's not really where we're focusing on. Although with MCI, I have here, after a TBI, MCI could be warranted. Severe anxiety and depression, right? Mood, as Deanna mentioned, infections, vitamin deficiency, and a lot of our RNs and medical staff. I'm sure that you've all seen this at some point. That could impact just general cognition. But for cognitive deficit, I have it here as kind of like this more general term, right? That kind of encompasses, and I'll read, because I think that this is a really great point. It's disruption of an individual mental processes that may lead to the acquisition of information and knowledge, but does not impact their overall ability to function appropriately, right? So they can still function appropriately, but it's kind of like the underlying mechanisms that may not allow them to function at the highest level, which again kind of reinforces, during treatment, we are asking a lot out of these clients. And so in many cases, you do need to be functioning at a pretty high level to get the most out of it. Do eating disorders impact cognition, right? So big part of the talk, right, is kind of talking about that intersection. And I'll just ask you all, you don't have to put it in the chat, but I'm just curious as to what you were thinking. Yes, no, maybe, it depends. I'll answer that question here in a bit, but I'll start with what we know eating disorders do impact, and I'll go through this quickly because I'm sure you've heard it many times from other presenters, or probably earlier in the day as well. Eating disorders impacts quite a bit. Our medical presentation, first and foremost, comes to mind. That's a fact. We have an amazing team of RNs. I'll just quickly shout out the RNs I work with: Sarah, Jacqueline, Danny, Allison, and Anna's here as well. Amazing team of RNs, and we have them here, and they play such a huge role with us because medical presentation is impacted by EDs. Social, relational, family, psychological, psychiatric, all impacted as well. Research backs it up. Also, some research that demonstrates that persistent EDs can have similar dysfunction to severe mental illness, right? Which is an interesting point. I included that there because it takes me back to when I was in my doctoral program, and we would go over kind of like general psych, and we would spend so much time on like the schizophrenic spectrum, or like the psychosis spectrum, right? The like delirium, brief psychotic, to delusional disorder, and then what is it? Schizophreniform, schizoaffective, so on and so forth. And we get to eating disorders, and it was so fast. And it was like every time that it was brought up, it was just like, oh, okay, this group doesn't eat enough. This group uses compensatory behaviors, and this group was kind of other specified. Good, right? And maybe that's one of the reasons why it kind of drew me to this population. But I always found that to be really interesting, right? Is I think sometimes the general public, right, forgets that the impact that eating disorders has long term. General testing has been done throughout the decades. The two things that are related to cognition that I find really interesting is we're pretty certain that cognitive rigidity and impulsiveness are parts of the cognitive profile, right? So we can kind of think about our individuals who are a bit more ritualistic in their patterns, right? Very rigid. I gave a CE talk on RODBT, which was directed precisely at cognitive rigidity, right? And then the other end of it is impulsiveness, right? And kind of what that looks like, why that's there. We know that it's a part of it. And I bring these up, not just to say that, we know these are here, but also because we see them in cognitive testing as well. It's really interesting. So cognitive rigidity can be shown when we do like task switching assessments, right? So these individuals, it's very hard for them to switch tasks and to perform well, right? So individuals who are not cognitively rigid, I would be able to give you, multiple tasks to do and say, stop and do this, and there shouldn't really be a beat missed, right? But individuals who do have this trait, then this presentation, it's really challenging for them. And so again, I ask you to think about that in the clinical sense, in groups and individuals. How does the cognitive rigidity come into play, right? And are we being mindful of that? I really love these studies. There's a few of them. I couldn't include too much because then this will just turn into like a literature review, and I don't want it to be that way. But just to kind of reinforce, like, does eating disorder impact cognition? Possibly, but there's an interesting study that looked at gray and white matter in our anorexic nervosa patients. Granted, small sample size. Long story short, though, the anorexia nervosa group that was shown to have smaller brain volumes and globally decreasing gray matter. They also had decreased gray matter across the cerebellum, temporal, frontal, and occipital lobes as well. The correlation here, right, was that the gray matter or the decrease in gray matter was there was a correlation with how long the ED was present, which will be a theme. And just to quickly outline that our gray matter, so that kind of conducts the majority of the information that we kind of see as cognition, right? And then a couple more studies to just reinforce that fact. So I'll start. I meant to put Bodo et al. At top of, but just starting here, they also found so there weren't any differences in the white matter, which is more sensory based, but they observed significantly lower volume of gray matter in the cerebellum. Again, huge cognitive area in our brain, and then there was performed where it was like baseline, and then they retested following treatment, and they found that there was increased volume of the orbital frontal cortex and medial temporal lobe, which is right here, like our language center, going into our frontal lobe as well. So like a lot of language processing, auditory processing. And they identified the changes as being flexible reward-related learning and episodic memory pathways. It's really interesting. So yeah, eating disorders do impact cognition, but it's quite complicated, right? It's not straightforward. There's so many different things that go into it, and we discussed a lot of variables. But when our clients come in, right, we have this presentation, and of course, the eating disorder is why we are all here. However, there's many things that can impact that. Mood, personality disorders, medical presentation, types of behaviors utilized, just kind of traits in general, right? So it's really hard to control and say, well, yes, there's a direct correlation. But studies have tried, as you can imagine. So we'll take a look at just 3 and then move on to the next part. A lot of words on this slide, and please do not read all of them. I just wanted to include the exclusion criteria on the left. They try so hard to control for a lot of the things that would impact cognition, even, which I think is really rare sometimes, they put an IQ control on there, or IQ exclusion criteria below 80 using the National Adult Reading Test. So they utilize the trail making test, the brief assessment of cognition and schizophrenia, CAT fluency, the CPT, which is the Connors, which is the trademark for ADHD, letter number sequencing, Wechsler memory scale, HVLT is the Hopkins verbal learning test, BVMT is the brief visual spatial memory test, then the neuropsychological assessment battery. And then the last one is this emotional intelligence test. And I don't remember the MS. I think it's like May or something, but it's emotional intelligence. What findings did they see? Both groups scored lower in the visual learning, which, again, thinking about what that means clinically, and social cognition domains as well, right? And this is kind of the theme throughout, right? Is there's this impact, and it's not just in eating disorders, but specifically with long-term eating disorders, there's this decrease in social cognitive abilities, right? So then the question is, well, is that necessarily due to the eating disorder? Does that predate the eating disorder, and the eating disorder just exacerbates it, right? We also talk a lot in the eating disorder community about the eating disorder being quite sneaky, right? And likes to be closed off. So does this have something to do with it? So many variables could impact that. Our binge purge group scored significantly lower in processing speed, attention, and reasoning. And then there were some other differences in there as well. Really interesting study. And this was done in 2018. So following PHP, which I think is really relevant for us. So again, similar exclusion criteria. They included the test of brief intelligence, which is the TIB, the Wisconsin card sorting test, the Ray complex figure test. IGT is the Iowa gambling test. It's like a process of has you choose very quickly. So it looks at processing speed, the matching person and technology, and then there's an abbreviated mental test that they used. So some relevant findings: poor executive abilities, right? So kind of the frontal lobe. And what was interesting was the autobiographical memory. Right, so that's something that I was surprised to see, but I have seen that a couple of times in other studies as well. But again, I mentioned this earlier, so poor task switching and abstract thinking ability. So this could be linked to the cognitive rigidity that we talked about compared to the controls. And then the last one of these, I promise is the last one. Grau and colleagues in 2019, they looked at eating disorders, both short and long term, just to identify if there was a significant difference. Similar exclusion criteria: less than 2 years was classified as short term, more than 10 as long term. So they did the Stroop test, trail making test, which is processing speed or executive functioning, Tower of London, there's a spatial task, Ray complex. And then the Hailing sentence is just a sentence completion, and Wechsler vocabulary test. Right. So again, what we would assume happened, right? The long-term eating disorders had more significant cognitive impairment, but there was no significant differences found between short-term eating disorders and the control group, which is why I say it's a bit complicated, right? And that leads into I think it's always, especially when we're talking about studies, it's always important to include both sides. So there's many studies that say, wait a minute, we need to take another look at this, right? There's some things going on that don't support, right, that cognitive abilities decline. But the interesting thing with these studies, and I put a lot of these here, is that they're looking at short-term eating disorders, and a large majority of them are looking at young adult and adolescent. So what we see is that what we may already know, right, just kind of being reinforced, is that early detection of these eating disorders are really significant. And if there are cognitive declines, right, early detection and treatment is really impactful, right? So what are some of the reasons that there isn't significant cognitive decline? It could be the type of eating disorder, just kind of generally, like our bodies interact differently with certain symptoms and behaviors. And then also the idea of, what is it called? Neuroplasticity, right? Where our adolescents, right, their mind isn't fully developed yet, right? So there's a lot of pruning going on, right? That could protect against it. And just briefly, if you're wondering what this is, the original Ravello profile, which was used to one of the first kind of like batteries specifically for eating disorder clients with cognitive concerns. Okay, so now we move into the attesting part of this presentation. So I hope we have a good understanding of what cognition is, why it's important clinically and just day-to-day functioning. We know that there is a relationship, whether it's strong or not, that's for you to decide, with eating disorders and cognitive deficits. But in terms of testing, what can we do? Why will we need it? What's the purpose of it? I think we have to start in 2006, National Institute of Neurological Disorders and Stroke. They proposed kind of these two like levels of virtual testing for cognition. I just want to be clear that this is not specific to eating disorders. This is just generally with cognitive testing. So the first level is going to be just global cognitive efficiency tests. The gold standard of these, the MMSE, the mini mental. I'm sure many of you are familiar with that, especially if you've worked or practiced in the medical setting. And then the MoCA, which is the one that I'm really familiar with, the Montreal Cognitive Assessment. These are very, very, very quick. They were originally developed to tease out dementia, but have been shown to be reliable in kind of identifying cognitive decline. So this is a really good precursor just to identify, does this individual need a little bit more cognitive testing? Like, would it be worth looking into? And I think I have, okay, so yeah, the MMSE is here to the left and the MoCA is on the right. Just going to flash those up because the ethics behind showing test data, but I think you can find those kind of generally on Google. They're all over the place. But I'll quickly show. So here and on the MoCA, the visual spatial executive and the naming, right? There's a MoCA called the blind MoCA. So in 2019, when we were doing a lot of cognitive testing virtually, one of the things that we did was doing the blind MoCA, right? So you're only kind of doing the verbal assessment of it, which is really helpful. At that time, there wasn't a lot of research into it, but we were just trying to do the best that we can. This was at the Dallas VA, and we had a ton of testing that we had to go through and just kept getting backed up. So, and the MMSE is also something you can do virtually. So if you go onto the MoCA website, right, there's an option for virtual testing if you're trained in that area. The second level cognitive test, which is the ones that I'm interested in, Hopkins verbal learning, the California verbal learning, the Ray auditory verbal learning, and the trail making test, the Boston naming test, and then the Ray complex figure test. I didn't write all of those out just because it's so much. It takes up so much of the screen, so that's why I'm just saying them. But these are kind of your really basic brief cognitive tests that a lot of times are paired together, right? So TMT, the trail making test, that's a processing speed or executive functioning test, is very, very brief, right? It's similar actually to the top part of the MOCA here, where you're asking them to kind of follow the trail. And it gives good indication of, how quickly somebody's able to process, right? If there's like slow processing. The Ray Volt, C Volt, and H Volt are all really good memory, and it looks at kind of different levels of memory, so working memory, short-term memory as well, and so on and so forth. I'm not going to go through all of these, but what the NINDS also mentioned was that we need to kind of understand, like, yes, these are feasible tests, and there is literature behind it, but is it feasible to do it? Right, reliability came with more research on these tests. Are we capable? Like, are we fully capable of doing it? Can we control for the environment and some of these other things? A big one is the normative data. Is the data normed and for a virtual population? Right, now there are more norm data, but at the time there wasn't a lot. Right, the technology there, of course, that is not an issue anymore for the majority of individuals, especially referencing to this program as well, and patient characteristics and digital literacy as well. So I think the digital literacy is something that we'll talk about here in the next few slides. Right. I pull these figures from Salvadori and Pantone 2023. They kind of reviewed, what's the efficacy of all of this? Why would you want to do it? Why would you need to do it? Well, I think that some of those questions are rhetorical. I just wanted to briefly put this up, right? Video conference, we have real-time interaction, of course. There is the option for supervision as here as well. Excuse me. We have environment control, so we can help kind of construct the environment in the way that we want. Make sure that the door is closed, that nobody is coming in. We can have the camera pointed down, similar to supported meals, right, to kind of see what they're doing and how they're doing it. And also screen sharing is an option. And then we don't have automated data acquisition, but it's really hard to do that even when you're in person, because you're doing raw data, right? And then you're scoring afterwards. I'm going to skip this one for time, but this is just like a flow chart of how you can come to video conference versus in person, and then the level of evaluation. Which brings me to the R bands. This is another really popular cognitive assessment. I really enjoy doing this one. When I was at Bintab, when I would see eating disorder clients there or patients there, this is one of the ones that we did quite often. And there was actually a study going on, which is why we were doing the R bands all the time. So the R bands is a repeatable battery for the assessment of neuropsychological status update. It consists of 12 different subtests that will provide 5 different cognitive functioning scores. I really like it because it only takes 20 to 30 minutes to administer in person and virtually. That number has stayed consistent. In the 5 domains that I was referencing is immediate memory, which can also be broken down into working memory, visuospatial constructional, which it may not be super relative, right, to kind of like the clinical setting, but it's good data. Attention, language, and delayed memory as well. So I like it because this is one where you don't have to pull so many different tests. This has 12 subtests, and if you find that there is a significant deficit, then maybe bringing in another test to kind of support that and kind of identify, okay, so we know that I mentioned earlier, right, the temporal area, like our language center, If we know that there's an impact there, right, let's bring in something like the rate volt and see if it's auditory processing, if it's auditory learning, right, things like that. So I took this from the Inter-Organizational Practice Committee in 2020. And this is the R-band. So they kind of discuss like what input and output you would need. So just very briefly, the BSD, brief spoken directions, or something like the SS is spoken stimuli. So they did a really good job of coding each subtest, which is on the left, each subtest and what you are going to need to do for that, right? And then the output is what they would be doing. Does that make sense? I also took this table from the IOPC, which again, it's I think lovely, and I really there's so much research on the different types of. I just chose the R bands, but I really could have highlighted so many tests because there's been so much research done over the past few years to identify, what needs to happen if you're going to do telehealth testing or telepractice. And it gives, again, all the subtests on the left and then the considerations. So just for these, I'll kind of quickly go over these bullet points. Requires high quality audio for both examinee and examiner. Do not repeat any item or trial unless it was not heard due to technical problems. So we want to try to recreate the in-person effect as much as possible. And then plan ahead to address repetitions in cases where a word or story was not heard due to technical problems. So you may be wondering, like, okay, well, there's a lot more error that could possibly be intertwined in this testing, and that is true, right? So there is accounted for error, just like there's human error in in-person testing, right? So what we want to do is try to do our best to ensure that we have, or we're trying to control for as many as variables that could be present. But again, really, really cool. I really enjoy this. That sounded very nerdy, but I do enjoy the considerations. I mean, it kind of walks you through exactly what you need and why you need it, what to look out for. So the recommendation, and this is I didn't have the citation on this slide, but this is also from the IOPC. Recommendations is obviously making sure that we have informed consent. They know what the testing is and why it is done. Privacy and confidentiality, right? So making sure that the link is locked, nobody else can get in. Making sure that the assessor is competent in what they're doing. The type of assessment is answering the testing question. Of course, licensure, right? If you're able to give an assessment and in what state. And then lastly, the technology piece of things, right? We want to make sure that we're trying our best to hit all of these proposed recommendations. And again, this is kind of like the bare minimum. We could go much more into depth into the recommendations that should be going on, but this is really just the bare minimum. Having this puts us at an advantage for cognitive testing, and then reliable cognitive testing, which is the most important. So we're getting close to the end of this presentation, and I haven't really answered, why would we want testing, right? And I hope that the takeaway isn't that I'm proposing that all clients who are diagnosed with the eating disorder and co-occurring diagnoses need to be tested, because that is not the case, right? But we need to, or I think it would behoove us, right, to be aware of which clients may be at risk for cognitive deficits that would place them at risk from not hitting certain milestones or expectations as it pertains to treatment, right? Which is, I hope that's what you've heard throughout, right? Is that this is, I think, an area that we can all pay attention to a bit more, right? And make sure that we are kind of aware. I'll just quickly give you a story, not story, but an experience. I had a client not too long ago. They discharged, treatment complete, really very happy for them. But when they first got here, I got a message from Grace, and Grace kind of wrote something to the effect of, I'm not sure what's going on, but there seems to be like some challenges with memory, and I'm not sure if it's cognitive or not. And I met with the client. I also had a BPS shortly after the goal setting session. And it was the same for me. Right? It was like, okay, something interesting is going on here. So as Grace does, she did quite a bit of digging and identified that there's a mild cognitive impairment diagnosis with this client. So it wasn't on the intake. They didn't tell us kind of generally when they were meeting with people, but that's something that shaped their time here. Did that discovery ultimately lead to large changes in their treatment map and kind of treatment trajectory? No, right? But there were definitely considerations, right? With my time with him, and Lindsay was the RD on that case as well. We made sure that we repeated to them kind of specifically like what we wanted, where we wanted to challenge them, and different expectations outside of programming. We had them write down many different things. There were so many sticky notes and kind of just kind of different aids to help them memorize. They were more of a visual learner versus auditory learner, right? So I came up with more, I did a lot more screen sharing and kind of typing in. And I do think that all of these things are helpful, right? And again, it's just a consideration when it is there versus we would never know, right? So when to consider testing, and this is just general testing, not just virtual testing, but just even if we're sending in person, any changes in cognitive functions, obviously, right? Any onset or course, change in functional status, especially self-care, if there's like really steep declines, physical symptoms, psychiatric symptoms, and then medical presentation or new medical presentation or diagnoses, right? But then generally just kind of how we feel as well, right? There's a lot of weight in the clinical interview and what that can provide, and we need to listen to that as well. Okay. And I just popped these figures back in. And before I get to psychodiagnostic testing, which is my last slide, I also kind of want to make clear that a lot of times, especially if we're doing specific cognitive testing, and this was true at Bintop as well, or excuse me, at the Dallas VA, is that we would do testing and then it would be kind of like general non-specific testing, and if we would find something very specific, right, or we find something that we're like that the data there, like it's the scaled scores, quite low, and we're kind of worried that there may be a little bit something else going on, right? That's where we would refer for full neuropsych testing. Again, I just want to emphasize that, I'm talking a lot about telehealth testing, but I think that there's a place for that, right? But it may not always be the answer. Okay. So for instance, like the client that I was referencing, we referred them or wanted to refer them for additional testing. So they had the MCI diagnosis, but it was many years ago. And so we asked them to get retested. And so I'll end with, hopefully, maybe I'm getting ahead of myself. I want to kind of set up a talk for psychodiagnostic testing at some point. Because as much as I've talked about cognitive testing, and that's my first love, I really do enjoy cognitive assessment. I think that there's just testing in general can provide us a lot of information, specifically psychodiagnostic, right? And psychodiagnostic, when I say that, I mean a way that we can kind of identify, which diagnoses are present. Maybe we're identifying underlying diagnoses. Definitely diagnostic clarification, right? So we get clients in all the time that have these at times really complicated presentations, and they were diagnosed from one physician, and then there was a mental health provider here, and then somebody else given other diagnoses, and it can be really confusing, right? A lot of times I ask my clients, like, do you feel that diagnosis fits, right? Because I think that they should know, right, what's kind of on their chart. And there'll be a lot of times where it's like, no, like I don't think that fits, right? Or I'm not really sure. And so while there's a lot of information that we can learn from the clinical interview, another tool that's out there is personality testing, right? The MMPI-3 just released about a year and a half ago, something like that. But my favorite, the 2RF, I think is really, really helpful for our adolescents, the MMPIA, the PAI, and so on and so forth, right? And then you compare that with other assessments and other questionnaires to kind of give a really good understanding of what's going on with symptom severity. Does that meet criteria? And again, it's just a way to understand our clients and meet their needs as best as we can, right? I think it's always good to make sure that we're not overdiagnosing, also we're not underdiagnosing, and that the diagnoses that we get are accurate, right? Because those diagnoses can lead to certain treatment mapping, right? And we want to make sure that it is accurate. So I just wanted to dedicate one small slide to the importance of psychodiagnostic testing, and hopefully I'll be back to talk about that. Ton of references. But if you have any questions, or actually, Ashley, I'll let you take over.
Thank you, Ronnie. And if anybody had anything additionally that they want to ask, feel free to put that in the chat now, and we can get some questions going. We did have a couple roll through. One question was, have you found that a specific eating disorder impacts cognition more than another?
So I did not find that in the studies. What's interesting is there's actually across the board, long-term eating disorders in general equal or can lead to cognitive deficits or at times cognitive impairment. A lot of the studies, to be honest, were focused on anorexia nervosa, restricting type. But of the studies that included general eating disorders, and actually the short-term versus long-term eating disorder, that was general eating disorders. So I think kind of like the general idea is like, oh yes, X group is possibly more malnourished, therefore they would have more cognitive decline. Well, that's not incorrect. That's also not the whole picture.
Perfect. Thank you. Another one that was asked was, how would you manage a client that has multiple cognition impairments? Example, substance abuse and an eating disorder.
It's really difficult. It's really complex, right? I think so I've used the term control for a lot in my presentation, right? And that's just kind of like the research talk, right? But I would also want to control for everything that we can, right, with that client. So especially with substance use, are they still using? Trying our best to decrease that use. And that's, it's really hard to kind of identify the extent of cognitive decline, especially when somebody is still using, or we'll just include sleep, right? When there's really disturbed sleep, it's really hard to say, okay, this is actually, cognitive deficit versus a variable that's impacting cognition. But to wrap up that answer, for me, it would be more kind of a behavioral approach, right? Making sure that any behaviors that are contributing to cognitive impairment or cognitive deficits are looked at first and foremost, because possibly depending on the amount of deficits, they may not be able to really interact with treatment at a high level, right?
Wonderful, thank you. Another question that rolled through was, is there a specific way to treat and test those on the autism spectrum for cognition in regards to having an eating disorder like ARFID?
A specific way, I don't think that there's a specific way. And so my experience, this is just my thought, that is really challenging. The ARFID and ASD co-occurring, I think, is really challenging to treat, and also really challenging to test as well, because as I mentioned, there's so many variables that go into it. So there's not really a gold standard to test for both. You would have to kind of just create your own battery and look at it. So it would, a lot of it really would just be focused on just the general ASD, the severity of the ASD, like what that presentation looks like. As we know, with ASD diagnoses, it would be on a spectrum, right? And kind of identifying, okay, where are the deficits in this, and utilizing that to kind of help tailor treatment. But then obviously the other variable there is the eating disorder, and that's, yeah, that can get very complicated very easily. But I would say that if there isn't any baseline testing, definitely referring for testing, and kind of seeing, because also, I know this answer is long, but also, as we get older, if we were diagnosed with, let's say, ADHD or ASD as an adolescent or a youth or a young adult, as we get older, and there's not specific treatment for that, we just try our best to work around it, right? So things change over time, and maybe our deficits that were deficits are now strength, but other areas are deficits. So having a good picture of what's going on, I think, can help lead treatment.
Perfect, thank you. We have time for one final question that came through. Do you find any barriers to test for cognition virtually versus being in person?
Yes, for sure. So the amount of tests that you can get through something like Pearson or Q Global is not an exhaustive list of the cognitive tests out there, right? So if I had a concern for cognitive impairment and I was in person, whatever, and I have a pretty extensive like testing kit and forms, I could kind of just pick and choose, right? Like, well, I could do the Rayvold, I can do subtests of the waist, I can do some things here, and I can also do like motor components to it as well if I need to, but virtually it's kind of limited, right? And the problem is that so there are tests that the research shows that you can use them, but it's really difficult to use, right? And there's kind of other variables, I think, that could impact the efficacy of it, right? So yeah, definitely barriers, and that's why I really stuck to just the R bands. It's been proven to be very reliable. It's been proven to really not miss a beat virtually or in person.
Wonderful, thank you. Just to wrap things up, I really want to thank Ronnie for providing this space for us and giving such a great presentation. And I just want to extend a thank you to all of you that are present here and for sharing this space with us. We do have some great events coming up in the next 2 days with Summit, so feel free to check out those. And I just want to again thank you for coming here today, everybody, and for Ronnie for providing such a great presentation.
Thank you, everybody. Thank you, Ashley.
Of course, everybody have a great rest of your day and be sure to check out those other Summit events.